Thank you, Chairman. I'm Junhwa No from Korea. I apologize the president change. Dr. Kim is not coming due to strike the hospital labor. Sorry. Today, my presentation topic is anterior depth of prostate, morphological factors associated with the Novo urinary incontinence following HoLEP. The Novo urinary incontinence is a relatively common complication after BPH surgery. After TRP, incidence of the Novo urinary incontinence is about 30 to 40%, usually urge incontinence. After HoLEP, incidence of the Novo urinary incontinence is about 40%, slightly higher than after TRP. Transient urinary incontinence after BPH operation is usually improved within a relatively short time, but incontinence can lead to a significant stress and anxiety to patient during its duration and impact on patient quality of life. There is a lack of studies on the Novo incontinence after HoLEP, so we investigated the factors associated with the Novo incontinence after HoLEP. We thought that morphological characteristics of prostate may be associated with the Novo incontinence after HoLEP. 223 patients included, and follow-up period is more than 6 months. Morphological characteristics of prostate by transrectal ultrasonography, such as size, width, depth, longitudinal diameter, presence of intravesical prostatic protrusion, posterior depth, and anterior depth. Enrolled patients were divided into two groups according to the presence of urinary incontinence. Independent t-test was used to compare between two groups. Logistic regression analysis was performed to investigate a correlation with the Novo urinary incontinence. For dissection of anterior adenoma, cystoscopic sheath should be taken down. And so operator give a force to sheath down. We thought this force delivered the urethral sphincter and it caused the mechanical injury. This figure shows measurement of anterior depth of prostate on transrectal sonography. Anterior depth of prostate was defined diameter from prostatic urethra to anterior prostate capsule. This is my results. About 30% of patients has urinary incontinence, but these two groups, age and anterior depth of prostate is significantly higher in transient incontinence group than non-incontinence group. In the other parameters, such as prostate volume, retrieved tissue weight, operation time, it is no significant differences. Logistic regression analysis of transient urinary incontinence is only anterior depth of prostate is significantly differences. In conclusion, about 1/3 of patients might undergo transient urinary incontinence follow-up HoLEP, and most of them might have been resolved within 1 to 6 months. Anterior depth of prostate on transrectal ultrasonography is associated with the Novo urinary incontinence after HoLEP. Anterior depth of prostate on TRUS could be used a practical tool to predict post-operative transient urinary incontinence. Thank you.
Did you make any attempt to identify the type of incontinence that these patients are suffering from? Was it a detrusor overactivity incontinence or urodynamic stress incontinence? Did you do a urodynamics on any of these patients? What was the type of incontinence? Or a clinical stress test? I mean, how did you decide what type of incontinence these patients had?
First time we didn't urodynamic study, but nowadays we do urodynamic study. So we collect more data now. So it's
So then on the basis of your symptomatology, did you try and stratify them as whether they were primarily urgency incontinence or primarily a clinical stress incontinence that you would
usually stress incontinence.
Peter?
The silly question is, why did you operate a percentage of patients? I'm asking this because what you show in your tables is prostate volumes and standard deviations. And if I calculate the range and see what's outside the standard deviation, which is by definition 25% at the lower end, then almost 10 patients in every arm have a prostate that's less than 20 cubic centimeters or milliliters. What has been the problem of those men that made you operate them?
The prostate size is, I agree the prostate size is very important, but my data is very small and low, preliminary data. So I agree the prostate size and operation time is also important.
Good, thank you.
Were they all obstructed?
Shirish from Pune, India. Is it okay to ask?
Please.
Have you considered any other factors that could have been responsible for a higher incontinence rates in those patients who have got a larger anterior prostatic volume?
Yes, I totally agree. But we collect more data and we will be back.
No, but I mean, technically speaking, there are so many other factors to be considered. And if you say that if the anterior volume alone is responsible for a high rate of incontinence, then this statistic should also apply to open enucleation as well as robotic enucleation of the prostate. Would you agree? The same calculation, the same incidence would also apply to other modes of enucleation of the similar group. For example, an open enucleation or a robotic enucleation.
So do you think that if you do another technique, you would have the same parameters to find out what will be happening after the surgery?
So nowadays, I usually rotate the cystoscopy sheath because the range and laser fiber is downloaded. So rotate the sheath is more safer.
Yeah, that's your presumption that could be responsible. So in that case, open enucleation or any other enucleation would have a lower rate of incontinence because it does not deal with overangulation of the scope.
Yeah.
I think I disagree with this. Everybody who has experience, who is old enough to have experience with open, simple prostatectomies, knows that the bigger the prostate, the easiest procedure is. So if the small prostate, you're struggling in enucleation. And this is what they are seeing here. Small prostate is very difficult to find the plane when you have to, like a surgical capsule, we used to call it. So I don't think it's the pressure. I don't think it has anything to do with the position of the scope in the urethra, but the identification of the right plane where the laser is used to enucleate.
That's crucial. Yes.
And the other comment I have, I'm not sure I understood Peter's comment. So how is size correlated with obstruction? So we have patients with a small prostate, them having an obstruction, and patients with large prostate with no obstruction. So
of course, some patients with small prostates have obstruction, some men. But simple clinical epidemiology
Well, you can offer something else, not an
you can
enucleative
have a
procedure.
pulmonary infection tomorrow and not know now. So everything can happen, and incidents happen. But a rule of thumb, and we all know from all the literature, all the basic teaching books that we have, that BPH is prostates around 30 grams or larger. And that's not for nothing. That's because then the symptoms begin to arise. And exceptions on the rule are there. But
There are
10
a few
to 20,
exceptions on this.
20 surgery.
If you're doing clinical practicing urology, you will see a lot of patients like this. That they need some this obstruction, which can be pharmacological. Which
It is by the lack of good. It's by the lack of good urodynamic workup in every patient before surgery. Is that you think that you know that a lot of patients with prostates of 20 gram have bladder outflow obstruction.
Yeah,
I can say with urodynamics, and we cooperate with the military hospital and get young men. I do urodynamics in young men from 20 to 102, and prostate size is perfectly correlating with the chance of bladder outlet obstruction between 30 and 60 gram. Above 60 grams, something strange happens, and below 30 gram, there's absolutely a very, very, very low. There's a higher incidence of bladder neck outflow obstruction and bladder neck dynamics, but small prostates are not obstructed unless otherwise proven. And the incidence is 5% or less, below 30 grams.
Thank you, we need Novo.